Nerve-sparing retropubic radical prostatectomy from the Martini Klinik, Prostate Cancer Center, Hamburg, Eppendorf. Our preferred equipment for this procedure consists of 3.5 and 5 magnification loops and xenon headlights, a 5 and 3 mm rectangular clip applicator, a certain needle to control the dorsal vein complex and to perform the anastomosis, and a self-retaining retractor. For the first part of the video, the symphysis is on top of the picture and the bladder is at the bottom. After a midline skin incision, the retropubic space is established. The incision of the endopelvic fascia. The endopelvic fascia is incised, fibers of the levator ani muscle are gently pushed away. The attachment of the detrusor apron, known as the puboprostatic ligament, is isolated and dissected. Incision and selective ligation of the dorsal vein complex. A stay suture is placed lateral in the endopelvic fascia before the dissection of the vein complex begins. For preserving of the underlying neurovascular bundles, the ligation is limited to the area between the 10 o'clock and the 2 o'clock position. A clear preservation of the sphincter muscle is reached by limiting the selective ligation on the endopelvic fascia and the fascia of the sphincter muscle. The circular fascia of the sphincter is marked blue. The lateral parts below the incision are called Müller's ligaments. Müller himself called them ischioprostatic ligaments, separating the sphincter from the neurovascular bundle. The suture is passed superficially through the dorsal vein complex, just distal to apex of the prostate. The suture is not cut, for it will be used once the dorsal vein complex is divided for the selective ligation. An additional suture is placed in the midline of the prostate to avoid back bleeding. The dorsal vein complex is clearly visible and now incised, again without any ligation. Blood loss at this part of the operation is usually moderate. Once the dorsal vein complex is completely dissected, fibers of the urethra muscle will be clearly visible. By selectively suturing only the endopelvic fascia and fascia of the striated muscles surrounding the dorsal vein complex on top and below, no functional tissue is incorporated into the ligation. The use of the circumferential needle allows a quick control of the dorsal vein complex and avoids any tension on the functional structures. The nerve-sparing procedure. These illustrations demonstrate the principle of the neurovascular bundle preservation. The fibers of the neurovascular bundles run adjacent on the lateral and lower part of the prostate. The dissection should be started high up on the ventral aspect of the prostate in order to preserve as many nerves as possible. The parapelvic fascia is gently lifted and incised. The area between the prostatic capsule and the fascia contains the areolar tissue, which contains the nerves, fatty tissue and vessels. Now it is undermined by a small overholt, clipped, and finally it is dissected. When the right dissection plane is entered, one will see the shiny surface of the prostatic capsule and a layer of the Denonvillers fascia covering the neurovascular bundle. It is very important not to use any coagulation. Small bleeding should either be clipped or selectively sutured. Towards the apex, the dissection line is directed towards the 2 o'clock position, towards the urethra. Special care should be taken at the apical region as the density of crossing vessels is highest at this area. The principle of our nerve-sparing procedure is first to mobilize and lateralize the neurovascular bundles before the urethra is dissected. The urethra is nicely demonstrated here, as is the mobilized neurovascular bundle and the apex. The triangular space between the urethra, the apex, and the neurovascular bundle is shown here. Preparation of the urethra. The outer part of the two layers of the sphincter muscle consists of the striated sphincter muscle covering the outer surface of the apex prostate. The muscle fibers are gently pushed distally. Laterally, Müller's ligament needs to be incised. Then, the inner side, built by the longitudinal smooth muscle fibers, is dissected close to the apex. The muscle fibers covering the apex of the prostate are gently pushed distally until the longitudinal muscle fibers are visible. This maneuver allows a precise preparation of the apex and preservation of the whole length of the functional urethra. After preparation of 2/3 of the circumference, the longitudinal muscle is sharply dissected. The prostatic apex is clearly visible and is not touched by the dissection. Then the rest of the longitudinal fibers are dissected. Principle of anastomotic sutures. The anastomotic sutures are placed at the 2 o'clock, 5 o'clock, 6 o'clock, 7 o'clock and 10 o'clock position. Stability of the anastomosis is guaranteed by passing the upper needles through the ligated dorsal vein complex. In a second step, the needle is then passed through the mucosa of the urethra. These two steps guarantee that only a small part of the functional tissue is incorporated. Incision of Denonville's fascia and preparation of the seminal vesicles. This part of the operation is shown from a lateral view. The prostate is gently lifted up after insertion of a urinary catheter. It is important to mobilize first the paravesical fat to the lateral side. Then the prostatic pedicles, also known as prostate pillars, become visible. Once the pedicles are isolated, they are undermined, ligated and dissected. Denonville's fascia is incised at the basal region for preparation of the seminal vesicles. Damage on the neurovascular bundles by dissection or traction during preparation of the pedicle is avoided by starting the dissection high on the paravesical fat on the upper part of the pedicle again without any traction. Denonville's fascia, covering the seminal vesicles, is left inside as it protects the neurovascular bundle. Finally, the deferential duct is isolated, clipped and dissected as well. Removal of the prostate and bladder neck reconstruction. The bladder neck is opened and the catheter is pushed through the prostatic urethra to lift up the prostate. Little by little, the prostate is released from the bladder. A tennis racket suture with an eversion of the mucosa is performed. Its closeness is tested with an overholt. Completion of the anastomosis. A single knot technique is used in order not to compromise the blood supply for the sphincter muscle and the bladder neck, producing a stricture rate below 1%. Note that the 6 o'clock suture includes the Denonville's fascia and the raphe of the sphincter for traction of the whole membranous urethra. The needle is entered through the mucosa, takes a part of the bladder wall, and care is taken that it is also passed through the mucosa again for exiting. The operation field with the bladder approximated to the urethra with tight sutures is shown here. To check the anastomosis, the bladder is filled with physiological saline. Closure of the 8 to 10 cm skin incision is performed with a continuous intracutaneous self-resorbing suture.